Okay, so now we're going to go over inflammatory heart disease. And let's talk. There's a variety of diseases that are considered under inflammatory heart disease. And let's just have a moment of silence. Isn't it so sad that your heart ever has to have inflammation? I mean, yes, it's kind of nice. It gets a little bit of attention, but it's so sad. So, a little moment of silence for that poor heart that's feeling inflamed tonight. Let's go on. All right, so let's start with infective endocarditis. So when you're thinking of infective endocarditis, think infection in the heart. And if you're thinking of infection in the heart, I mean that already doesn't sound great, but if you think it's in the heart, especially because we learn that infective endocarditis hangs out a lot on those valves within the heart, then what are we concerned about? Well, we're worried about where it can go. If it's in the heart and on the valves, what do the valves do? They open and close. And if the valves open and close, that means that they can literally spew all that bacteria that's hanging on them, all that infection to the rest of the body. Because the heart leads to everywhere, because that's how cool and important it is. So risk factors, of course, for infective endocarditis, and this is important. There's risk factors for all of these. And you won't see me go into risk factors usually, and for all of these topics, but I want to tell you about risk factors because it's really important to help differentiate. Because a history on a patient with infective endocarditis is so important. A lot of these patients with infective endocarditis, they may have heart disorders or other things that put them at risk for getting infective endocarditis, but a lot of times it's because they had something inserted in them that was not clean. And I'm not just talking about dirty needles and drug users and stuff like that. Like sometimes central lines or other devices are inserted, and that's how they end up getting infective endocarditis. So I need to get a good history and see if they've had any devices inserted recently. Are they using any drugs? Do they use needles, etc.? That kind of stuff, because that's going to really tell me what they're likely to have. Most of these patients don't come in and say, hey, I have a problem with my heart. Most of these patients come in and they're showing signs of infection. They can show some of these strange signs like the joint pain, and we'll talk about the others, the node spots and lesions. But a lot of these patients, when they come in, they're just showing signs of infection, but we don't know where the infection's coming from. And that's why it's so important to get a history. Most of these patients will get a blood culture and other stuff like that to see that they're growing something, but to figure out where it started, usually we have to get like an echo or something else, and we can actually see the bacteria in the heart if it is infective endocarditis. But that's why that history is so important, so we can kind of know what we need to look for. So, like I mentioned, this patient's probably going to have just signs of infection. That's how they're going to come to the hospital. They might have fever, be weak, loss of appetite, that kind of stuff. And then they can also have joint pain as well. It's one of the strange things. The heart is very connected to the teeth and to the joints. And so, a lot of times when you have a heart problem, you're going to have the same manifestations in those other, sometimes the teeth, cause the heart problems, vice versa, etc. So, yeah, definitely, we'll talk about that here in a second. But joint pain is another manifestation that a patient with infective endocarditis can have. There's also node spots and lesions. And so, I always tell students when you're looking at all of these disorders, try to think about what's different or what's going to set this apart from everything else you learned. So, a lot of these cardiac disorders that you're studying, they all sound the same. They have like similar symptoms. The patient's tired, weak, can't breathe, fluid overloaded, blah, blah, blah. Like it's a lot of the same stuff. No offense, to you guys. I know that all of your disorders are very hard, but I'm just saying a lot of them sound the same. So how are you going to differentiate them? You need to think of what's different between them, not what's the same. So there's like something that's different about infective endocarditis is effectively there's all this bacteria that's getting spewed out from the heart to the rest of the body, and it actually this bacteria lodges in different areas, and it causes nodes to form, spots to form, and lesions to form. And these are all like, literally pieces of bacteria clogging your circulation and things like that. And it can be very painful and uncomfortable. So, general treatment for endocarditis, and pretty much what am I focused on? Like, what is my goal here? How am I trying to, help this patient? Of course, this is infection. So, what am I going to do to treat infection? I'm going to use antibiotics. I might support them in their circulation with some fluid, and I'm going to treat their fever. Most likely, they're going to need long term antibiotics, which means this patient's probably going to go home with a PICC line. So, they're going to need some extra education about how to manage that. Additionally, where I want to manage their pain, like I said, there's joint pain, they have those painful lesions. So, treating that pain as well can be helpful to them. Of course, first and foremost, if I can, I'd love to prevent infective endocarditis. And so we can prevent it by, like I was mentioning, the teeth and the heart are very closely connected. And so people that are really high risk, if I've already had infective endocarditis, if I have valve disease, if I already have heart disease, I can be at high risk for getting infective endocarditis. So if I need to go have dental work done, a lot of times if I'm high risk, they're going to give me prophylactic antibiotics to prevent me from needing to, or not needing to, but prevent me from going into infective endocarditis. Regular dental care is going to be important. And then identifying those that are high risk and that need to receive prophylactic antibiotics is key. And I think all of y'all's textbook has like a list of who needs to receive those prophylactic antibiotics. And then, of course, I also want to prevent this by teaching just general infection prevention. If they are using needles or having drug use, like teaching them about clean needle programs or other ways that they can, if they're not interested in quitting or ready to take that step, ways that they can at least prevent these kind of complications. And general infection prevention, because sometimes people get infective endocarditis because they have like pneumonia or they have an infection somewhere else. So, how as a whole can they take good care of their hygiene so that they don't get infective endocarditis? My overall goals for a patient with infective endocarditis is I want to manage their infection and prevent, of course, any complications from that. You're going to see this one pretty much for every single disorder that has to do with cardiac, adequate cardiac output, aka perfusion, oxygenation to my tissues is always going to be my top goal there. Being able to keep that stability. Because if I don't have blood flow, I'm pretty screwed. so, I need to have that cardiac output. I need to have that blood flow in order to get perfusion to my organs and my tissues. Energy conservation, you're going to see this as a very, very common thread, throughout a lot of these PowerPoints about cardiac, is in that I need to conserve energy. Or in other words, a lot of these patients that have inflammatory conditions, cardiomyopathies, valve issues, et cetera, they're going to have a lot of issues with tolerating activity. So I need to teach them ways that they can kind of manage, like where they can still do activities without getting too exhausted. So I'm going to teach them ways to balance rest and activity so that they can still have a good quality of life without overstressing their heart. I'm also going to tell them about, or I'm going to be really focusing on monitoring and watching for complications. So a lot of bad things can happen with infective endocarditis, sepsis, shock, and all the rough stuff. So I really want to be watching out for those as I'm taking care of this patient. So the next carditis, the next itis is pericarditis. And this is an inflammation of the sac of the heart. Or what we call, I kind of think of it like it's so sweet. The outside sac of the heart is trying to give the heart a hug, but sometimes it just squeezes a little too tight. So effectively think of it kind of like it's almost like a constriction around the heart. The sac around the heart is just getting a little too tight, like we're in like a tight belt, and it's inflamed, it's irritated. So, what does this patient really look like? They have sharp pain, especially when they take a breath in or inspire. It hurts to take that deep breath in. And you're also going to notice a rub. And there's two types of friction rubs. There's a pericardial friction rub, which is a heart friction rub. And there's also a lung friction rub, which is called a pleural friction rub. And, how am I going to tell the difference between these effectively? If I want to see if a patient has a friction rub, which effectively think of it like sandpaper rubbing together. It literally it's a very grating kind of sound. If I want to see if they have that, what I'm going to do is I'm going to have them hold their breath and then listen to their heart. And if I still hear that kind of like rubbing sound, it's kind of like sandpaper rubbing or a grating sound, that means that they probably have a what do you call it, a cardiac or a pericardial friction rub. And that's because if they're holding their breath and I don't hear that sound, that means it's coming from their heart, not their lungs. This patient's going to feel better when they're leaning forward. So you're going to see them going off into the tripod position. It's going to be the only position that's comfortable for them because it actually displaces the heart and makes it's more comfortable to sit in that position than it is, what do you call it, in like lying back, etc. It's going to put off some of that pressure from that inflammation. Um, and then this patient's also going to complain of trouble breathing commonly. So we're going to be looking for those signs and symptoms too. This can lead to tamponade or cardiac tamponade, which is effectively, think of this as like, hey, the heart's getting a hug right now with the pericarditis. And then if their hug gets to be too much, it gets to the point where the heart is so constricted, it cannot contract. And so what we do with this, it's what's called Beck's triad, and there's 3 symptoms. And these are like anytime there's like a triad, you always need to know it. It'll be on some exam. If not, your complex exam. I'm sure you will see it somewhere in your future on the NCLEX or something like that. Or when you go and get your certification as a certified critical care nurse, you're going to love it. So, effectively Beck's triad, you have low blood pressure, hypotension, you have a neck full of fluids or JVDs. That's where you get the extra, like the backup of fluids from your heart into your neck. And then I also say you have ear muffs on your heart. So think of it, it's like constrained so much, like, kind of like think of something that's like, covering something else, but it's so much constriction that you have muffled heart sounds. You can't hear anything. So think like ear muffs on your heart. So you can't hear anything. All the heart sounds sound really distant because literally it's kind of like the heart cannot move. And there's all this, extra inflammatory fluid around it, squeezing it to death so where it can't, properly contract. And one of the other things that, I always like to point out is one of the things that's different about pericarditis that is helpful in the diagnosis is we get an EKG on them. So if a patient presents with a lot of things that look like pericarditis, we're going to get an EKG on them. And one thing we're going to notice that's different, because remember, I always said you always want to figure out what's different about this patient than all these other disease processes. And one of the other things that's going to be different is, you learn about when a patient has a heart attack that they have ST elevation, which is a sign that effectively, I'm not getting perfusion to a part of my heart to the point that my electrical activity in my heart's being affected. When I have a heart attack, it happens in one, maybe 2 coronary, hopefully only one, but maybe 2 coronary arteries. And so when I look at an EKG, I'm going to see ST elevation, but I'm only going to see it in so many of these boxes. Like you can kind of see there's, this is what they call a 12 lead EKG. So there's effectively 12 places that I'm looking, or 12 different views of the heart that I'm looking at. So if I'm having a heart attack, I'm going to see ST elevation in just a couple of these because I'm not having, again, it's not every single one of my coronary arteries that's having a problem. But what's interesting about pericarditis is even though it's not actually, like it's not a heart attack, these patients have ST elevation too, but they have ST elevation in every single lead. So every single, in a 12 lead EKG and the 12 different views of the heart, every single one shows ST elevation. So that's another way that we can tell that this is pericarditis. So what are we going to do for this patient? First and foremost, we want to treat whatever the cause is. So if it's infection, we're going to treat the infection. If it's, autoimmune, we're going to use steroids. We want to treat the inflammatory process and their pain by giving them non-steroidal anti-inflammatory drugs or NSAIDs. And again, positioning, head of bed elevated, teach them that tripod or leaning forward position. That's going to be more comfortable for them. If they have a tamponade, we're going to need to do an emergent pericardiocentesis or pericardial window, and that's what's in this picture. This is literally where they cut out a, kind of like an opening, like what is a window? It's an opening, to the outside, and so they cut open a part of the heart to allow for drainage of this fluid. If there's so much pressure, so much of that, fluid literally strangling the heart, that what they have to do is they have to usually create this window, and they usually put a drain in to drain that fluid from the heart so that there's less pressure on the heart and the heart can pump the way that it's supposed to. And a pericardiocentesis is usually like a needle aspiration where they just go in, they stick a needle into the lining of your heart, and then they draw back some of that fluid to relieve some of the pressure on your heart. So of course, again, my goals are adequate cardiac output. It's all about the tissue perfusion and, getting oxygen to my tissues and cells. I'm going to be concerned about pain management because, again, we talked about in a different PowerPoint about, with chest traumas, how we're going to be worried about them being able to breathe adequately. If I'm hurting so bad, and especially if I'm hurting every time I take a breath in, I'm not going to be taking deep breaths. So I need to manage that pain so they're able to take deep breaths so that I don't start getting pneumonia or a respiratory complication. Energy conservation is also going to be important to these patients. They are not going to feel like running any marathons, but we want to teach them about, balancing rest and activity healthy, and so in order to improve their quality of life. And then I'm also going to monitor and just generally watch them for any complications, things getting worse. And tamponade is one of the worst things that can happen in these patients. So really looking for those that Beck's triad: the hypotension, JVD, what do you call it, and we call it what was I gonna say, muffled heart sounds. So, on to the next one, myocarditis. So, when you hear the word myo, you always think of the muscle. So, this is a inflammation of the muscle of the heart. And it can lead to, of course, since the muscle of the heart is the pump, it can lead to malfunction of the pump. And when you have a malfunction of your pump or your ability to squeeze, a lot of times it looks like heart failure. So the symptoms can vary in myocarditis, but usually the patient's going to have pain because it's going to, what do you call it? This is an inflammatory process. So, of course, there's always going to be usually pain associated with that. They're going to be tired because literally their heart doesn't have the strength to pump the way that it's supposed to. So, they're not going to be getting as much blood out, which means they're not getting as much oxygen out, which means they're not getting their energy that they need to those cells to give them that energy that they need to function. And they can also have signs of heart failure. If I'm not adequately squeezing, my blood has no thing to do but to back up. Um, because the symptoms vary in myocarditis and it looks a lot like other things, these patients with myocarditis, they can look like a patient with pericarditis. So the only true way to diagnose that it's a problem in the muscle is by doing a biopsy of the muscle tissue. So they would have to go in and take off a poor little piece of the heart and go and examine that tissue under a microscope and see if it is myocarditis. That's the only way to diagnose this definitively. And don't worry, that's not something we do as nurses. Um, the treatment for this is we're going to treat the symptoms. We really want that adequate cardiac output. And so the treatment's going to vary depending on the patient. If they have signs of heart failure or impending heart failure, I'm going to treat that. I don't want to cause any more damage to the heart. So I'm going to do things that are going to slow down that process where, like, when my heart's not working, other things try to come in and help, like my fight or flight and my RAS system tries to help. So I need to start blocking those with ACE inhibitors, ARBs, and beta blockers. That way my heart is not working so hard. It needs to not be pumping too fast, and I need to not be holding on to too much sodium or water because have too much vasoconstriction or resistance to fight against in the blood vessels, because otherwise that's a lot of work for my poor heart. I also maybe want to decrease fluid load, especially if I have fluid backing up, but I do not want the heart to have to work too hard. So if I have a lot of fluid on me, I'm going to give diuretics to kind of help with that workload. I may also use a positive inotrope like digoxin, which is going to help to push my blood out to the rest of my heart. Because if they have fatigue, I'm going to encourage bed rest and then also teach them those energy conservation techniques. If they're having trouble breathing, I'm going to keep the head of bed elevated. And of course, I might also give oxygen if it's ordered. And then I want to decrease that workload of the heart and prevent complications. This patient with myocarditis, again, it ends up kind of like heart failure. And so they may need an LVAD or a left ventricular assist device or a balloon pump to help support them until their inflammation subsides. Or long term, if it leads to a cardiomyopathy, they may end up needing a transplant or something else, depending on the cause. And then oxygen therapy as well, just to help support it. Because anytime the heart is having to work harder, it's going to have an increased demand for oxygen, and a lot of times it's going to have a decreased supply because it's using more as it's trying to fight off whatever's going on. Myocarditis can commonly be caused by infection processes and things like that. So all of your oxygen might be busy working, to try to help with that infection. So it's not going to be able to help and be available. So sometimes giving extra supplemental oxygen can help with those additional needs. So last but not least, let's talk about rheumatic fever or rheumatic heart disease. So when we're talking about rheumatic fever, I know when I first came to nursing school, I always thought this was talking about like a respiratory infection, but rheumatic fever is actually an inflammatory heart condition. And this is an inflammatory heart condition that affects all the layers of the heart. And that's an acute process. Over time, from getting that rheumatic fever, from getting that inflammatory heart disease that's affecting all the layers of my heart, I can actually have a problem with my valves. And it's like a scarring and deformity of my valves. And this is a chronic disease that can come, all starting, I should mention, from a strep infection. So, those strep infections that kids get all the time, that's where a lot of times this starts. This rheumatic fever always will start with a strep infection, and that's one of our important diagnostic tests that kind of differentiates these. Is that it's hard to diagnose because sometimes they don't currently have a strep infection, but they have recently in the past. But yeah, so at the end of the day, it leads to this scarring and deformity of their heart valves, which, anytime you're thinking of, a problem with your heart valves, that's a problem getting blood out to the rest of your body. So it's a cardiac output problem. So this client, kind of like with the infective endocarditis, where they had all those funny named things, rheumatic fever, rheumatic heart disease also has funny named things too. So they have this, and I'm not going to try to pronounce all of these and embarrass myself, even though I don't mind being embarrassed every now and again. But I know you guys can read. So, but I always think for the first one, this is kind of the picture that I have here. Think choreography. It's like a weird jerking movement that they can sometimes have. They can also have, these little like rings that they can get on their torsos and inner surface of their limbs. That's a skin manifestation of this disorder. And they can also have these painless nodes on their joints. So you kind of see again, it's kind of that strange thing, that weird connection between um, heart problems and joint problems as well. The heart's connected to everything. So overall, I want to treat, of course, the infection. If they have a positive strep test, I want to treat the strep with antibiotics. For pain, and if they have a fever, I want to use NSAIDs and steroids to help treat some of those symptoms. As a whole, as always, bed rest and energy conservation, teaching them to kind of utilize that rest, and then do some activity, rest again, do some activity. We really want to decrease the stress on that heart. We don't want to do anything to, make it worse, or have to work harder. My goals again are going to be adequate cardiac output, and this is going to be pretty much the same as a lot of the other ones we talked about. Adequate cardiac output, head of bed elevated, give them oxygen if ordered. We're going to do pain management, like we already mentioned, the energy conservation, like we mentioned, and really watching for complications, making sure that nothing's getting worse. Because, keep in mind things like this, like how they're all connected. Like if I have had rheumatic heart disease, which scars my valves, I'm more likely to get infective endocarditis and have other issues with my valves. And then maybe I need to have valve disorder, and then I need to get a valve replacement. So you see how these are all connected. So if I can at a baseline, try to prevent infection, try to prevent strep, or be monitoring it closely, I can hopefully prevent some of these from happening and further complications and further heart problems. Because, we all at the end of the day just want to protect our beautiful hearts because they're the most important organ after all, right? So yeah, so hope this was helpful. I'll see you next time.